Hey everyone, and welcome back to Mastering Medicine video lecture. Today we're gonna continue our iron deficiency anemia lecture. In first part, we talked about iron metabolism and its absorption, and also we talked about Hep C. If you haven't watched the previous part, please watch previous part and then come to this part 2. So in today's lecture, we're gonna talk about pathophysiology of iron deficiency anemia. Then we're going to talk about causes of iron deficiency anemia. Then we'll talk about signs and symptoms of iron deficiency anemia. Then we'll talk about, we talked about iron profile test in previous lecture, but we'll talk about it a bit today also. Then we will talk about diagnosis of iron deficiency anemia and differential diagnosis of iron deficiency anemia. Then we'll talk about management of iron deficiency anemia and its treatment. Okay, and also we'll talk about follow up of this iron deficiency anemia patient. Okay, so in previous lecture, we talked that anemia. We defined anemia that anemia is when a normal level of hemoglobin or a hematocrit or RBC drops below its normal range. Okay, so this is called anemia. Okay, and normal range of hemoglobin, hematocrit, and RBC is depending on some factors, and these are uh, uh, these are lab values, different lab values. They're dependent on age, on gender, on physiological state, and so on. We talked about it. Then we talked that iron deficiency, when we have less iron, so it causes less synthesis of hemoglobin, and when we have less hemoglobin, so the cell uh, becomes microcytic and hypochromic. Okay, and then we talked about this very important part today because I want to link the sign and symptoms to this part. So iron has some other functions also. For example, it has role in oxygen transportation, it has role in DNA replication, it has role in ATP synthesis and production. We talked about all of them in first part. Okay, it has role in enzymes, it has role in neurotransmitter. For example, it has role in synthesis of dopamine, and also it has role in collagen synthesis and keratin and so on. Okay, now first of all, let me classify iron deficiency. Okay, here we have two terms. Do not confuse these two terms together. One, we have iron deficiency. One, we have iron deficiency anemia. Okay, here we have two terms. First, here I'm only talking about iron. Okay, not on iron deficiency anemia. So to know about the iron deficiency, you have to know about iron profile that we talked in part 1. But to know about iron deficiency anemia, okay, you have to know about CBC, okay, plus iron profile. So now, first of all, I'll classify iron deficiency, not iron deficiency anemia. So I'll classify iron deficiency based on its pathophysiology, based on its mechanisms. So I'll divide it into two parts. One is called absolute iron deficiency. Another one is called functional iron deficiency. What do I mean by these two terms? In absolute iron deficiency, I don't have iron. Okay, I don't have enough iron in my body. This is true iron deficiency. Okay, for example, when I lose a lot of blood, okay, so I lose a lot of RBC, I lose a lot of hemoglobin, I lose a lot of iron. When I my intake of iron is less, for example, I take less iron in diet, so I'll have less iron in my body. So this is a true iron deficiency. But in functional iron deficiency, it means there is iron sequestration. What do I mean by this? I have iron in my body, I have iron storage in ferritin, hemosiderin, and so on, but I cannot use it. This is the problem. I cannot use it. Okay. For example, I have inflammatory disease. For long term, we'll talk about it. I have inflammatory disease for long term. So in inflammatory disease, my body secretes what? It secretes hepcidin, and hepcidin prevents from iron absorption. Okay. Now, very shortly, okay, we talked that when we take a, when I'm now going to talk about these two terms, okay, to compare these two terms here in this part. Now listen me carefully. We said in previous part that when we take iron in our GI system, it goes to the duodenum. Iron can be absorbed in stomach and in early part of jejunum and also in duodenum, but its important part is the duodenum, okay, that we absorb iron. Now, this is a duodenal cell, okay, we talked about it. So we take iron to the duodenal cell by a protein which is called divalent mineral transferase 1, okay, and we take iron in Fe2 plus n Fe2 plus, okay. If I take Fa3 plus iron in my diet, the ferric form, I have to convert this iron before entering to the duodenal cell by an enzyme which is called duodenal cytochrome B, okay, and then it's transported to the duodenal cell by DMT1, and sometimes AV2 is transported by another protein which is called HPC1, okay. Now I'll transport this iron to the blood, okay, but transportation of iron is occurred from this apical side to the basolateral side by a protein which is called ferroportin. So this is a protein which transports iron here from the apical side to the basolateral side, and this is called ferroportin, okay. So now when I have inflammation, so a lot of hepcidin will be secreted in my body, and this hepcidin inhibits this ferroportin, so I cannot take iron, so I will not have iron in my body, okay. And that's one problem. And another problem, do you know that hepcidin inhibits macrophage, okay. So when macrophages are inhibited by the hepcidin, so we cannot recycle the iron from the macrophage, so that's why we cannot use the storage form of iron which is inside the macrophage. And the most important iron that's used in our body, this is recycled iron, that's around 20 to 25 milligrams per day, okay. So that's why in inflammatory disease I cannot recycle that iron, so that's why there is problem in functions of the that's why this is called functional iron deficiency. It means I have storage of iron but I cannot use it, okay. Then this is very important because I want to link this part to this part, okay. Now this iron is then transported to the blood circulation, and here in blood circulation we have a protein which is called transferrin, but before it's binding to the iron, it's called apotransferrin. We talked about all of them in previous lecture in part 1, but anyway, when apotransferrin comes in, it binds to the iron, this is called the combination or complex of iron plus transferrin is called the combination of iron plus apotransferrin is called transferrin, okay. So now this transferrin or this iron will be transported to different parts of the body, and it will be used by different tissues. Got it? Now come here. Let's compare first of all absolute iron deficiency with functional iron deficiency based on iron profile test. First of all, you have to know about these parameters. Point number 1, what is ferritin or what ferritin is? Ferritin is the store form of iron. It means I have iron in my body which is in store form, okay. Now in an absolute iron deficiency anemia. What is the problem? Problem is that I don't have enough iron. So it means this ferritin level goes down, okay, in absolute iron deficiency, okay. But in functional iron deficiency, here I have storage of iron, but I cannot use it, okay. So here the ferritin level should be normal or elevated. This is one point. Got it? Come here to the bone marrow iron. Do you know the best test for iron deficiency anemia to know about the everything about iron deficiency is bone marrow test, that we take a sample from the bone marrow and then we check it and look for it under the microscope. But practically in hospitals we do not prepare this test every day in everyday life. But anyway, here in absolute iron deficiency anemia we don't have enough iron, so it will be absent. So we don't have enough iron inside the bone marrow. But here in functional, we have a bit iron, enough iron to be provided to the bone marrow for the erythropoiesis. Okay, so it might be normal or it might be less. Got it? Come here to serum iron. Do you know about serum iron? This is the serum iron. This iron is and complex form with apoferritin. So combination of these two are called transferrin. Okay, so this transferrin, this amount of transferrin inside the our circulation is called serum iron. So in absolute iron deficiency anemia, the serum iron will be less because we don't have iron. And also in functional also it will be less. Why? Because we cannot recycle the iron, we cannot transport it from one part of the body to the other part of the body. Okay, now come here about total iron binding capacity. This is number 3. This is number 4, total iron binding capacity. What do I mean by total iron binding capacity? For example, this is transferrin. Okay, imagine that transferrin is like a track. Okay, we have 10 tracks to carry the iron from from one part of the body to the other parts of the body. Got it? So now if I don't have iron, so it means I have a lot of these tracks that they are empty. Okay, so these empty tracks or this amount of tracks that are now available for the iron, a lot of tracks are now in number and they want to carry iron, but there is no iron. So it means this iron binding capacity is increased. We have a lot of capacity, we have a lot of seats to bind to the iron, but iron is not available. That's called total iron binding capacity. So in absolute iron deficiency, the total iron binding capacity increases. Got it? But in functional, because bone marrow is not stimulated compared to absolute iron deficiency anemia, so it might be normal. Okay, or sometime it might be increased related to different situations. Okay, uh, decrease or sometimes it can be less. So this is very important that in absolute it increases. Okay, come here to transferrin saturation. Transferrin saturation means that how much iron is, how much seeds of this transferrin is saturated by iron. For example, I have 10 track and in each track I have 2 seeds. Okay, so how much seeds are available for iron? Okay, that's we calculate that by total iron binding capacity. But reverse to this, how much seeds are saturated or fooled by the iron, that's called transferrin saturation. Okay, and we can calculate transferrin saturation by dividing of serum iron dividing by total iron binding capacity times 100. We talked about it, and the net result will be less than 15% in iron deficiency anemia. But anyway, here transferrin saturation decreases. Okay, why? Because I don't have enough iron to bind to the transferrin. Okay, and about the functional part. Okay, and functional part, transferrin saturation, it might be normal or it might be decreased. Got it? Come here, this about SFTR, transferrin receptors. We explained that on the surface of RBC, we have a lot of receptors for taking the iron from the transferrin, okay, for endocytosis of transferrin. So these receptors are called transferrin receptors. Now, in absolute iron deficiency anemia, because we have less iron, so bone marrow is stimulated much more than functional. In functional, bone marrow is not stimulated so much because we have a bit iron inside the bone marrow. So this SFTR increases, okay, but here it's around normal. About the hepcidin, this is very important. In absolute, here is the problem with iron, not in my body, okay. So here hepcidin is low, okay, because this bone marrow inhibits the hepcidin production, okay. It tells the hepcidin that you will not be secreted at that time because I need a lot of iron, and you are uprooting that you inhibit iron absorption, so I don't need you. But in functional, there might be inflammation, so that due to that it might be increased, or if there is no inflammation, so it will be normal. Got it? I the iron deficiency is not related to these parameters which related to CBC, okay. So and HB will be normal because I'm not entered now into the iron deficiency anemia. I'm just talking about iron deficiency, so it will be normal, it will be normal. RBC count will be normal, it will be normal. MCV, mean corpuscular volume, will be normal. MCH will be normal, okay. It depends on different stages that when we enter to the, it will be normal, it will be also normal. Reticulocyte will be normal, all of them will be normal. About platelets, they will be normal, but here platelet is decreased a bit because sorry, here platelet is increased a bit, okay, because bone marrow is under hyper stimulation to produce a lot of RBCs, okay. Clinically, listen me carefully. Here we cannot find anything, but here there might be signs and symptoms of inflammation in our body, okay. And I don't need menstrual index here, it's related to other parameters. About CRP is a protein which is excreted by the liver during the inflammation. During what? During inflammation. So here I don't have problem, but here in functional it might be increased more than 6 or 5. It might be normal or increased. Got it? So that's why we say that iron deficiency might be due to, it might be absolute or functional. These are so important because during treatment of iron deficiency anemia, you have to treat two things. First, you have to treat iron deficiency anemia. Second, you have to treat the cause of iron deficiency anemia. So by these things, we can find cause of iron deficiency anemia. Got it? So now let's talk about the iron deficiency anemia. No. Iron deficiency. Let's talk about the iron deficiency based on their progression, okay. So that iron deficiency progresses in which stages that finally it causes iron deficiency anemia. So now we have different stages, okay, that a patient who has iron deficiency, not iron deficiency anemia, okay, he slowly enters to the phase in which iron deficiency anemia develops, okay, and signs and symptoms of iron deficiency anemia develops. So okay, so now what are these stages? Stage 1 and stage 2. These two stages are called isolated stage also, okay. In Harrison internal medicine, these two stages are studied under the isolated term, okay. So now in stage 1 and stage 2, or in isolated stage, we don't have iron deficiency anemia. But in stage 3, we have iron deficiency anemia. Second, in stage 1 and stage 2, we don't have enough iron in body, okay? But enough, it means we don't have enough store of iron inside our body, okay? The storage is depleted, okay? We have less storage, but we have enough iron to produce RBC, okay? So that's why in these two stages we don't have anemia or iron deficiency anemia. But what are the differences between stage 1 and stage 2? The only difference is that in stage 1, okay, we have only less storage of iron, but in stage 2 we have less storage of iron, plus we have less iron for erythropoiesis. We have a bit iron, but it's not enough for erythropoiesis, okay? And in step 3 we're entering to the iron deficiency anemia. Let me compare all of them here in this uh, parameter. Now, in stage one, the ferritin level goes down. Okay, we have less ferritin. In stage 2, it further decreases, and in stage 3, it's decreasing completely. Okay, it means around less than 15 up to 30, specifically around less than 15 nanogram per ml or less than 15 microgram per liter. Okay, these are the differences between stage 1, 2 and 3. Here about bone marrow iron, we have less. Here we have here here in stage number 1 we have enough iron to the bone marrow, okay? Here it decreases a bit, but in stage 3 the bone we have absent iron inside the bone marrow, okay? Here about serum iron, okay? Here serum iron is normal in stage 1 because we have only a depletion in ferritin or in storage a form of iron. In stage 2, okay, it decreases a bit, but in stage 3 it decreases completely. Here about total iron binding capacity, it's around normal, okay? Here it increases a bit, and here it increases completely, okay? Because here we need a lot of iron. About transferrin saturation, in transferrin saturation, here it might be normal or it might be less, okay? Here it's less, and here it's completely less. About it means here it's less than 15%. About SFTR, here it's around normal, here it will be a bit high, and here we have a lot of SFTR saturated transfer receptors inside the blood, okay? Here about the hepcidin, it's less, here it goes furthermore down, it will be less furthermore, okay, in these stages. If there is no uh, inflammation, okay. Now about HB, now here come here to the CBC report about the HB. Here HB in stage 1 it's normal, and stage 2 it's normal because here is no anemia, but in stage 3 now we develop anemia. It means hemoglobin level drops below the normal. That's why in stage 3 is called anemia, iron deficiency anemia. RBC count here in stage 1 it's normal, in stage 2 it's normal, here it drops, okay. About MCV, listen me carefully. MCV means main corpuscular volume, the main size of RBC. Here we have enough iron in stage 1 for bone marrow, so it's normal. In stage 2 there might be a bit. That's about what? About MCV. There might be a bit. You will find some small RBCs, but here you will find completely a lot of small RBCs, which are called microcytic RBCs. Got it? Or microcytic anemia. About MCH, do you know about MCH? MCH means mean corpuscular hemoglobin. It means inside one hemoglobin, how much inside one RBC, how much hemoglobin I have. This is called mean corpuscular hemoglobin. So here in stage 1, hemoglobin production is normal, and stage 2, it's around normal, or it might be less, but in stage 3, MCH drops. We have less hemoglobin synthesis. Now, MCHC. MCHC means, okay, the concentration of hemoglobin inside. Here it means amount of hemoglobin, how it's in picogram, okay? But here, concentration, for example, this RBC is, for example, this an RBC, this an RBC, this one RBC, this another RBC, okay? Now, this one here, this one is full up to this part, but this second RBC is pull into this part. So here concentration is more than this one. So this is called MCHC. So because in iron deficiency anemia we have less hemoglobin, so the concentration also drops. Okay, beside the size, and the concentration drops more than the size of RBC. That's why it causes uh, hypochromic RBC. Got it? So now MCHC, here it might be normal, it drops a bit, but here it drops completely. Got it? This is very important. RD. Do you know about RDB? For example, this is one RBC, this is another RBC, this is another RBC, this is another RBC. When you compare these RBCs, okay, there might be a lot of difference between the size of this RBC with this RBC, more than 15%. Okay, so this weight, this increasement in the weight of this ratio, it means increasement about the size between space about the size between two RBC. That means that RDB increases. Okay, so if one RBC is very large, another is very small, so it means we have a lot of difference based on size between these two RBCs. That's why we say that RDB increases. So here in stage 1, sometimes in stage 1 it increases a bit, in stage 2 it increases a bit more, and stage 3 it completely increases. It means I'll have one small RBC, one large, one small, one large. Got it? About the reticulocyte, here the reticulocyte is normal, okay, in stage 1 because there is no anemia. In stage 2 it's also normal, but in stage 3 reticulocyte drops. Okay, about the platelets, here in stage 1 it's normal, no stimulation of bone marrow, here it's normal, but here bone marrow is stimulated so much because bone marrow needs to produce a lot of RBC. So beside the RBC it produces a lot of platelets. Got it? Clinical, here clinically patient is normal, here it's also normal. In stage 3 the sign and symptoms of anemia will be developed, that we'll talk about it later on. Okay, about Menzer index, we don't need it here. Okay, it's for another purpose. Got it? About CRP, there is no problem with the CRP. Got it? So these were classification of iron deficiency based on stages. Got it? Now I'll talk about iron deficiency anemia, that when a patient is entering to the stage of iron deficiency anemia, so we will first classify iron deficiency anemia, that what are the causes of iron deficiency anemia, then we will talk about signs and symptoms, and then we will talk about treatment and DDX of that. Great, super. Now let me talk about the patient who has iron deficiency anemia now. Okay, first of all, let me talk about the causes of iron deficiency anemia. Okay, it means, first of all, when I develop iron deficiency anemia, when demand is more than supply. It's a very important thing. Okay, it means supply to the bone marrow decreases, but demand increases. In these two situations, I develop iron deficiency anemia. So these things that I'm now talking about, them, all of them, some of them increasing demand in our body. Some of them are in, decreasing the supply to the bone marrow. For example, first of all, one major cause of iron deficiency, okay, is iron deficiency anemia is losing of iron from the body. In which situation I lose iron from the body? Okay, the first situation that I lose iron from the body is blood loss. Got it? What do I mean by blood loss? For example, this is a very important point. When an iron deficiency anemia patient to your department, okay, and you diagnose it as an iron deficiency anemia, first of all you have to rule out GI bleeding in the iron deficiency anemia patient, specifically in males and post-menopausal women. Got it? Now, because a lot of people who have iron deficiency anemia, they might have bleeding through their GI system due to peptic ulcers. Okay, each of them are specific lectures. Due to esophageal varices, okay, esophageal varices, that when we have venous dilation in esophagus due to liver cirrhosis, okay, inflammatory bowel disease, specifically ulcerative colitis, okay, cancers, GI cancers, and hemorrhoids. Got it? The next thing that you have to rule out is menorrhagia. Okay, it means in female, okay, that they're pre-menopausal, you have to rule out menorrhagia. Menorrhagia means that the period of menstrual cycle, or the blood volume of menstrual cycle, which is losing from the body during the menstrual cycle, the increases. Okay? So this is called menorrhagia. About postpartum hemorrhage, this is another cause of blood loss in our body. Okay, postpartum hemorrhage means that hemorrhage or bleeding after the delivery, that patient loses around more than 500 ml blood. Okay, the second thing which causes blood loss is active bleeding during trauma, during surgery, during epistaxis. It means bleeding from the nose, and during hematuria. Okay, it means blood from losing of blood through the kidneys and urine. And also another thing that a patient loses a lot of blood from his body or her body is due to blood donation. More repeated blood donation by a person, okay, and less time, more donation of blood. So there are causes of blood loss. Another cause of blood loss is they are all causes of blood loss. Okay, so these were related, that when we lose a lot of blood from the body, these were some conditions. The next condition that causes the patient to enter to the iron deficiency stage is that when iron intake decreases. Okay, for example, a patient who take less iron daily. Okay, for example, a patient who is malnutrition due to poverty, due to for example vegetarian people, okay, who eat always vegetables and so on during infancy, and when a small infant drink cow's milk, okay, during his life so much. About vegetarians, about the eating disorders, some people have eating disorders. For example, in bulimia, they eat something and then they stimulate their laryngopharynx and vomit it. Got it? The third thing, okay, which increases demand or decreases supply is iron absorption. Okay, for example, I've enough blood, okay, I don't have blood loss, plus I take a lot of iron daily, but I cannot absorb it through duodenum. Problem is in absorption. The most important thing that will be asked from you in board exam is about the celiac disease. Do you know about celiac disease? This is celiac disease. This an autoimmune disease to the gluten, that there will be a lot of inflammation inside the small intestine. Got it? And we cannot absorb iron due to inflammation. Plus, in gastritis, plus in different surgeries in different parts of our intestine, okay, plus pancreatic issues and tropical sprue plus Whipple disease. Tropical sprue is also inflammation of GI system, and Whipple disease is also infectious disease of uh, small intestine. So in these conditions, we have inflammation, and due to inflammation, we will face we will face two problems. First problem will be that we will damage mucosa of intestines, and we cannot absorb iron actively. Plus, during inflammation, a lot of hepcidin will be produced, and hepcidin degrades ferroportin, and we cannot absorb iron. Got it? The next cause is that it's related to the demand. It increases demand in our body. Okay, so in what situations the demand for iron will be increased? Okay, first is pregnancy. During pregnancy, patient needs a lot of iron. During lactation, okay, breastfeeding, during infancy, during fast growth, during high altitude. When a person is in a high altitude, there is less oxygen, so he needs to produce a lot of RBCs. So when he or she wants to produce a lot of produces a lot of RBCs, okay, so in that situation, the patient needs a lot of iron for synthesis of hemoglobin or RBCs. That's why demand increases. The next very important thing is that it's related to chronic disease and hereditary disease. For example, during chronic inflammation, for example, during chronic kidney disease, okay, listen me carefully. In chronic kidney disease, for example, this is a kidney, okay, this is our kidney, okay. Now, kidney produces normally a hormone which is called erythropoietin, and erythropoietin is very important for stimulating of bone marrow. Okay, so when we have less erythropoietin, we cannot stimulate bone marrow. So in chronic kidney disease, when we have chronic inflammation or damage to the kidney, we cannot produce enough erythropoietin, and when we don't have enough erythropoietin, we cannot produce enough RBC. Okay, so that's why patient enters to the deficiency anemia, specifically about iron deficiency anemia. Why iron deficiency anemia? Because in this situation also there is inflammation, so a lot of hepcidin will be produced in it, inhibits iron absorption. Got it? So that's why the patient develops iron deficiency anemia. Plus patient sometimes patient actively loses a lot of blood through the kidneys in the form of hematuria. Got it? Now, about inflammatory bowel disease, there is inflammation, and during inflammation, we have a lot of hepcidin, and hepcidin inhibits iron absorption. Okay? About the cancers, we have inflammation here. About the heart failure, okay, and heart failure also we have we have inflammation throughout different parts of our body. Plus in heart failure, okay, the demand increases because heart cannot compensate properly the body demand. So that's why bone marrow tries to make a lot of RBCs. So that's why in one side it wants to produce a lot of RBCs, and another side there is less absorption of iron due to inflammation. Plus, during heart failure, there is less transportation of energy to different uh, parts of the body. So metabolism of iron will not be occurred properly, the enzymes will not be worked properly. So that's why it causes iron deficiency anemia. Okay, and also during a iron deficiency anemia, heart failure patients will be affected so much. That's why sometimes doctors, when a patient has heart failure and it doesn't have, for example, iron deficiency anemia, they treat the heart failure patient with iron also. Okay, in autoimmune disease we have active inflammation. So that's why I said you before in previous lecture that if you wanna know about the diagnosis and differential diagnosis and mechanism of iron deficiency anemia, you have to know about the metabolism and absorption of iron in our body. Come here to one important point related to hereditary, in which we cannot absorb iron, in which we cannot transport iron. Okay, this is one disease is called iron refractory iron deficiency anemia. What do I mean? It means when I give iron to my patient, and after 2 weeks, when I follow up my patient, when I look at the result, okay, so patient does not respond properly to my treatment. Got it? So that's why this is called iron refractory. It means I give iron to my patient, but he or she is refractory to my iron. He does not respond to my iron therapy. That's why it's called iron refractory iron deficiency anemia. So why this occurs? Because here we have a gene which produces TMPRSS protein. Okay, so this gene is called TMPRSS mutation. The mutation in this gene causes a problem. This TMPRSS6. This protein is an inhibitory protein of hepcidin. This is very important. When we have enough TMPRSS6, so body will not produce a lot of hepcidin. So now, when I have mutation in this gene, so now I cannot inhibit the gene which produces hepcidin. So I'll have a lot of hepcidin, and hepcidin inhibits iron absorption. That's why when I give oral iron to the patient, he cannot absorb it. Got it? And also, sometimes mutation in DMT1 protein, and when I don't have DMT1 protein, I cannot absorb iron properly. Got it? So these were the causes of iron deficiency anemia in deep details. Got it? Now, come here. First, I'll tell you the sign and symptoms of iron deficiency anemia. Then, I'll tell you the differential diagnosis of iron deficiency anemia. But before that, come here. We can classify iron deficiency anemia based on severity also. Okay. For example, if my hemoglobin level is around 10 up to 12 grams per dl. This is called mild iron deficiency anemia. When it drops up to 7 up between 7 up to 10 grams per dl, it's called moderate. And when it drops below 7 grams per dl, it's called severe iron deficiency anemia, because it's very important during the treatment of anemia. Okay. Plus, based on morphology, I can classify iron deficiency anemia in stage 1 and in stage 2 of iron deficiency. There is no morphological change in peripheral blood smear, but in stage 3, which is iron deficiency anemia, you will find anisocytosis. What do I mean by anisocytosis? Anisocytosis means the size of RBC will be different. Some will be small, some will be large. That's why RDV increases. Okay. Plus, you will find poikilocytosis. Poikilocytosis means that you will have different shapes of RBCs. For example, some RBC will be biconcave, some RBCs will be pencil like this, long. Okay, they will be like this. Some of them will be like a target cell. Inside of this will be, for example, the periphery will be the center will be pale and the periphery part of this will be red. Okay, and that's due to the a lot of membrane. And sometimes sometimes you will find some other types of long cells, so different shapes of cells in peripheral bladder smear. Got it? Now let's talk about the sign and symptoms of iron deficiency anemia. Come here. Now let me explain the sign and symptoms of iron deficiency anemia. First sign and symptom of iron deficiency anemia patient will be that he or she will tell you that I'm fatigued. Okay, during the day I feel less energy in my activities. Okay, so that's why, because when you have less iron you cannot produce enough hemoglobin. When you cannot produce enough hemoglobin, you cannot provide enough oxygen to the body, and you cannot produce enough ADP or energy. That's one. The second sign and symptoms of iron deficiency anemia will be that he or she develops and feels general weakness in her or his muscles. Okay, so that's why uh, your patient feels weakness, easy fatigability during the day, and exercise intolerance. He cannot exercise properly. That's also because of less HB, less oxygen transportation, and less ADP production. The next sign and symptoms that you can find in your patient, it will be pallor. Okay, what do I mean by pallor? Pallor means that when you look for the conjunctive of your patient, okay, for the palm of your patient, you will look at it looks uh, pale. Okay, it doesn't look red. Okay, so that's called pallor, and it will be in skin, in palm, in conjunctiva, in nail beds. That's also due to less hemoglobin, due to less RBC, and RBC has red color. That's why the redness in this tissue drops. So they will be filled. Got it? Next is about the dyspnea and exertion intolerance. Patient tells you that during the exercise, I produce shortness of breath. Okay, it means shortness of breath mean that when patient exercises, okay, so during the exercise oxygen demands increases. Okay, so ADP demands increases, so body as a compensatory mechanism increases heart rate, and also body increases respiratory rate. So that due to this increasement of respiratory rate, patient develops shortness of breath. Okay, there is no enough air to enter, and patient feels that the air is not enough for me. Okay, that's called shortness of breath, and that's due to less HB, less and that's due to during exertion demand of oxygen increases, compensatory mechanism activates, and like this that I talked. So respiratory rate increases, feeling not good, and breathing is not enough for oxygen. Got it? Patient develops palpitation and tachycardia, and this is also due to compensatory mechanism. It means patient has less oxygen, so body as a compensatory mechanism increases heart rate, and due to this increasing of heart rate, tachycardia and palpitation develops. Palpitation means sensing of heartbeats on chest. Got it? This is due to less HB, less oxygen, more demand, activation of compensatory mechanisms. Okay, strong heart rate will be produced by heart. Plus, sometimes patient develops murmurs, systolic murmurs during during the contraction of the heart, and during the ejection of blood through the aorta, because blood is thin. It 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 goes from the left ventricle to the aorta very fastly and produces a murmur, which is called systolic flow murmur. Next thing, you will find koilenkia in the patient. Koilenkia means that nails of the patient look spoon like. Okay, watch this photo or image. Okay, so this is called koilenkia. Okay, and this is due to less production of keratin and less synthesis of collagen and connective tissues. Plus, patient will develop hair fall, okay, and dry skin. Got it? The next thing that you can find in advanced stages of iron deficiency anemia, you can find glossitis and angular cheilitis. Glossitis means smooth tongue, and this is that due to less production and less proliferation of cells, of epithelial cells, due to less iron, because we need iron for DNA replication. So patient loses pili on its tongue, and due to that, tongue will be smooth, painful, and red. Got it? Plus angular cheilitis, you'll find some fissures, some ulcers, okay, some crackles at the corners of the mouth. This is called cheilitis. Okay. Plus sometime you will find a syndrome which is called Palmer Vengeance syndrome. In Palmer Vengeance syndrome, we have three things: iron deficiency anemia, plus esophageal webs. Do you know about esophageal webs? Watch this photo. So about esophageal webs, okay, here will be a small fold of a mucosa of esophagus due to abnormal production of epithelial cells, okay, due to abnormal mechanism of epithelial cells, and due to these esophageal webs, patient develops dysphagia. Got it? It means not good eating. So next thing that you can find in patient of iron deficiency anemia, this is called restless leg syndrome. It means patient cannot rest their legs in one position during, specifically during the night. Okay, a patient feels a heaviness and pains on their legs, and this is related to the start to be that this related to the dopamine metabolism, because iron has rule in production of dopamine. Got it? Plus, patient will have less concentration because of less oxygen, less ADP. Patient will have headache due to less oxygen. Patient will have less appetite due to less working of enzymes, and patient will have pica. Do you know pica? Pica is also related to dopamine. Okay, pica means that patient is craving for non-food substances. Okay, for example, patient wants to eat ice. Patient wants to eat, for example, clay. Patient wants to eat soil. Patient wants to eat chalk. These are called pica. Got it? So these were all about the sign and symptoms of iron deficiency anemia. Now,